So I think we are ready to get started. This seems to be with us now. Welcome everybody here in this auditorium, and welcome everybody who's with us online. It's my great privilege to introduce Angela Chang for you today as the speaker. I'm also her proud mentor here at DS. I know most of you know her in advance, but I just want to briefly recapture that she has a master from Johns Hopkins University and her PhD from Harvard. Since after that, she worked at the Institute for Health Metrics at University of Washington, Seattle, before she came here to DS, and I think we're very privileged to have her here as a DS assistant professor now. Angela has a very mixed or international background, grew up in Taiwan and Japan, has an Italian husband and two wonderful kids, and is like that a truly global citizen, I think. And her work has also been within global health and global health economy, and she has an impressive CV there with an impressive list of publications in that area, and also a feature that I think is truly important for us here at DS. She's a super interdisciplinary researcher who has already bridged, she's officially with health, but already now working also with, or placed with social science, so bridging two of the faculties, and hopefully during your years here, Angela, even more faculties. I think your research and your area topic has the potential to really reach out. You are, and that's something that's close to my heart also, you're really motivated by making a difference in the world, and as such, I think you're just a perfect fit into DS and into SDU and the whole agenda of working on the SDGs as well. And then you have what is even more important to DS, you have new ideas, and I know you're going to present some of your former research today, but you're also going to present some of the new ideas which are so great that I myself am asking myself, is that really possible to do that? And I think that indicates that it's a good idea, it's a high quality idea that we're going to hear more about today. So with this, welcome, and welcome all of you.
Thank you, Christine, for the kind introduction. Just wanted to check if the back, can you hear me? So just keep in mind, like I've been here twice already in the past month, and I've been chatting with people on different topics, and even people with very different backgrounds. We tend to have things that we overlap, or I just like to learn more about. And so I hope you can keep me in mind as a person to just chat with or brainstorm ideas with. So just a quick introduction of who I am, and this is my research speed dating profile. And I've always struggled with the question of what I am in academia. So in academia, you're supposed to present yourself as, I'm an economist, or I'm an historian, I'm a physicist. And I've struggled with that, this question from the very beginning, and partly because it's due to my educational training. I've been trained in different things, and also my research interests have spanned quite widely. So I thought instead of giving you a label of what I am, instead of giving you a noun, basically, I would give you verbs and adjectives that describe what I do. So the first is what Christine mentioned is, and this is a term called multi-passionate. I learned recently from the entrepreneurship world, and it's the fact that I'm interested in lots of different things. I get joy of learning about different things beyond my research, and I would like to do things that are all over the place, basically, in some ways. I have, till now, mostly focused on studying public health, and I've applied methods and theories in health economics, health metrics, decision science, and epidemiology into answering my research questions. I am a quantitative researcher. I've done some brief qualitative work, but my strength is in quantitative research, meaning I use statistical methods to answer my research questions. And I think Christine, I think you know me too well. You know exactly my research speed dating profile, which is, I think it's only recently that I realized this last point. And so in my field, we're in the intersection between health, medical sciences, and social sciences. And you can be at a spectrum, either on the far end, to be very close to real life, to real impact of individuals directly, or you can be quite far, doing theoretical work. I used to be maybe more towards the middle. I used to analyze lots of data, looking at screens mostly, without interacting with people. And I used to be okay with that. And then I think it's more recently, this year or so, I realized that actually I prefer moving more towards real life impact among real people that I can see and interact with. So I'm slowly trying to move to that direction. So before I talk about the research agenda that I like to establish here at DS, I want to briefly give a history or current state of how measuring population health looks like, given that this is a wide audience with wide interests. So the research question that we in this field ask is, how do you measure health of a population? The easiest, most instinctive way to think about it is, well, what do people die from? At what age do people die? And when they're alive, what diseases do they suffer from? So these are the typical traditional metrics that people use. So deaths, life expectancy, incidence of a disease, prevalence of a disease. And it's only maybe about 20, I mean, there are some experts here, so you can correct me, but it's only about 20, 25 years or so ago that researchers realized that maybe these metrics are not enough to measure population health. These deaths and disease incidence prevalence don't capture how severe the disease is, how much people struggle from that disease, and the duration of the disease. And so 20 or so years ago, a group of researchers at the World Health Organization and then later at the Institute for Health Metrics and Evaluation, based in Seattle, they developed a metric called the Disability Adjusted Life Years, DALYs we call. And just for the experts and people maybe listening online, there are other metrics that you can do similar things that capture health. There's quality adjusted life year, health adjusted life year. For the sake of this talk, I'm just going to talk about DALYs, but there are criticism, pros and cons of different ones. But if you think about an average person who's fortunate to be born healthy, and he or she has a lifespan, and at some point they die. During their lifetime, they may have different times in which they suffer from certain diseases, and this frequency or intensity usually accumulates over, and it becomes bigger over time. And then at some point they die. And they may die earlier than what the life expectancy was supposed to be for that person. And so this DALY measure is a summary metric that simply adds up the number of years you lose due to early death and the number of years you lose due to having disabilities of some sort while you're alive. So it's a summary metric of morbidity and mortality. And in traditional metrics, you were not able to do that. You were just able to count how many deaths or how many diseases, but not both at the same time. And so with this metric, this group of researchers were able to study across all over the world. And actually, one reason they wanted to have this kind of metric was to be able to compare across countries and across time years. So one observation they made at that time before developing this metric was the fact that if you look at the number of deaths that people report from different disease groups or interest groups, you add them up, and it's 5 times greater than the actual number of people alive, or something like that. And so it was not comparable, and so this group decided to do something systematic. So they wanted to study across all countries from 1990 to whatever year, recent year, and across a whole range of diseases. So right now they have about 300 diseases or so that they count. And they do both number of deaths, number of diseases, prevalence, incidence, and DALYs. And so just to show you a couple of ways they present the data, this is how Denmark's, based on GBD, the Danish data of the whole entire population, both sexes, all ages, in 2017, measured in DALYs. The red shows infectious diseases, nutritional deficiencies, maternal neonatal health issues. Green is injuries, and then the rest is all non-communicable diseases. So this includes cardiovascular disease, a big chunk on the left, upper left, cancers, neoplasm cancer in the middle, and then we have mental disorders, diabetes, neurological disorders like Alzheimer's, substance abuse, and this, in total, there are about 300 or so diseases that they capture for every single country, and you can separate it out by sex, so by male or female. You can do it by different age groups. You can do it even within some of these diseases. There are sub-disease categories that they can go into. So it's very rich data that they've created. And you can imagine that this looks very different for another country or other countries in the world. And this, for example, is Ethiopia, where the majority of the burden, in fact, come from infectious diseases and neonatal maternal health-related issues. Another way of presenting this data is looking across time. So they are able to compare. The earliest year they have is 1990, and they move all the way. And every year they release new data information. So this is comparing Denmark, again, all ages between 1990 and 2017 measured in DALI rates. And so this is rankings, change in rankings over time. So I've highlighted the ones that have improved in rankings in terms of, meaning that they've become better in terms of rankings in green. So these include stroke, self-harm, so that's suicide, and road injuries. Red are the ones that have become worse in terms of rankings. So they include Alzheimer's disease, colorectal cancer, and alcohol use disorder. And with this rich, very rich information, they've been able to do lots of things. And it's sort of a dream for academics because they can just publish. Once you have the data set, you can just publish in any kind of cuts you want to make of this data. So there is the global burden of disease. There are local burden of disease. So you can do it by, for some big countries, you can do subnationals, like the US, you can do it by state. India, even the UK, they have it by subnationals. You can do it for specific countries and just look at that country. So for example, Norway has a strong collaboration with the Global Burden of Disease Project. So they have a group of people whose main job is to publish this for Norway specifically. In Denmark, we don't have that. And then you can also do it by disease. So looking at one disease, for example, colorectal cancer across all countries, across different years. So there are lots of cuts. And in fact, the Lancet, which is one of the most prestigious medical journals, has a specific section on their website just for this type of research because there's just so many coming out every year. And they're all quite interesting to see. And so this figure comes from the Nordic collaborators, Nordic Burden of Disease Collaboration, where they compared within Nordic countries plus Greenland as a separate one, and then compare between them to see which countries are doing better for certain diseases or not. So this is Denmark by sex, so females on the left and males on the right. And this is comparing to the average of the Nordic average. So the ones in green are statistically better than the Nordic average. So this is males for ischemic heart disease. And the rest that I've highlighted in red are the ones that Denmark is doing worse than their peers in Nordic countries. So they include chronic obstructive pulmonary disease, COPD, for both men and women, lung cancer for both men and women, breast cancer for women, and alcohol use disorder for men. So I did my postdoc at IHME, and I learned a lot by being there. And before going to IHME, one topic I've been working on was around population aging. So and you've probably heard this in many policy discussions around the fact that populations, especially in high-income countries, are aging, and we need to do something about retirement and social policies and things like that. And when I was doing that research, what bothered me, one question I had that bothered me was the fact, the point of how do you define old age? And usually in most countries, the way you do it is by setting a threshold of an age. So if you're over 65 or over 70, you're considered old. If you're not, then you can continue working and so on. But as you can, probably everyone has this experience where you've seen people who are 65 or older, and they're very healthy, or they're not the old as you think they are. In fact, I go to a gym in Copenhagen and I see people who look maybe like their 70s or late 70s, and they're doing the exact same exercise as I am doing, and I'm in my mid-30s. And these people, I don't consider them old at all, based on my personal definition. And so if you think about it, a 65-year-old in Denmark is likely very different from a 65-year-old in Ethiopia. Similarly, a 65-year-old in the current stage of 2020 is very different from a 65-year-old in 1990. So just setting an arbitrary threshold based on the chronological age of how many years you have lived is not, in my mind, a good way of defining who is old and who is not. And so my time at IHME, I created a kind of an aging metric that captures the health of people, not just based on their chronological age. So in this graph here, this is one of the analysis we did called the equivalent age analysis, where we looked at what the global average 65-year-old has in terms of age-related burden, and how can you compare it across different countries. So on the extreme side, at the top, you have Japan at age 76. And this means that an average 76-year-old in Japan has the same age-related burden as a global 65-year-old. On the other extreme, we have Papua New Guinea with age 45 or so, meaning that age 45-year-old in Papua New Guinea have the same age-related burden as a global 65-year-old. And with this, you can kind of get a sense of how healthy this person is, regardless of what their chronological age is. Denmark is 71. I pulled out some data for the Nordic countries, and similar to the previous ones, Denmark is not doing so well compared to their peers in terms of age-related burden. So now with global burden of disease, you have a good, not necessarily perfect, good metric of how you measure health, not just death or by the number of diseases you have, but the severity and the duration of disease burden. But similar to the concept of the question I had of a 65-year-old in Denmark being very different from 65-year-old in Ethiopia, you can also think about, for example, being blind. Being blind in Denmark and the experiences you have are probably very different from being blind in Ethiopia. Just in terms of blindness, it depends on the social cultural norms in the society. It depends on traffic in case of blindness, occupational support, early educational support, the healthcare system, the welfare system, so on. There are lots of things that impact how once you have the disease, how that affects your experience having the disease. One interesting example I read was about voice disorder. So people who have issues with having their voice out. And they compared people with the same disease and same disease kind of severity in Hong Kong and in the US, Philadelphia. And what they concluded was that people, even with the same disease and the same severity, people in Hong Kong perceive this disorder to have much greater impact in their life than people in the US. And the hypothesis was that it's a difference in how the culture is set up. So in Hong Kong, it's a more collectivist group dynamic kind of culture where you place a lot of value on communication with other people, versus in the US, it's a more individualistic society. That's what they hypothesized. They can't test it, but this is sort of what gets to the point of the fact that the context matters a lot in when you have the disease. And so thinking about what is the actual disease experience in a country, this leads me to the project that I would like to try to start here at DS. And right now I call it the Measuring Experienced Disease Burden, which is, can you measure quantitatively the experiences, or what are the impacts of the disease that it's not health related? So what are the other impacts of disease, non-health, broader impact of disease once you have the disease? And in fact, I realized, only when I came here that I realized there's actually an umbrella that I can think systematically about. But even before coming here, I've been thinking quite a lot about how the disease impacts different aspects of your life. So I did a study around how different health interventions affect equity of people. Among people, I've looked at healthcare utilization and how different people with different diseases interact with healthcare system, as well as the economic impact of diseases. So one way to motivate the study is, if you think about the recent coronavirus pandemic, you've seen that governments worldwide are expected to manage not just the disease itself, but other non-health aspects. So in the media, in political conversations, you often hear about welfare impacts of the disease, social impacts. Are people feeling lonely? Are people feeling anxious? What are the economic impacts of the disease? And so on and so forth. So this is a screenshot of a bunch of headlines from the New York Times from the past couple of months that talk about the broader impact of having the disease. And of course, infectious diseases are much more complicated, so I'm going to start with chronic diseases first. So as a thought experiment, I want to present this case to you, which is three groups of people, one group with breast cancer, another group with alcohol use disorder, and another group with depression in Denmark, so among Danish adults. And if we just look at three different dimensions, so if you look at economic impact, which is how the disease impacts your income, your employment status, and your expenses. Psychological impact, so your exposure to negative responses and feedback in your surroundings. And social impact, meaning how does the disease affect your relationship with your spouse or with your children or your social activities now that you have the disease. And this is a hypothetical example, so it may not be, it's very likely not accurate. But according to the Global Burden of Disease Project, these three diseases among adults have the same level of population level burden, meaning that they account for roughly 2% of the total DALYs in Denmark in 2017. However, you can imagine how these three diseases have very different impact on people's lives. Economically, breast cancer tends to affect high-income women. And so therefore, their economic impact, if you just look at income, changes in income, may be greater than people with alcohol use disorder, who may be primarily from lower income groups. At the same time, psychological burden, breast cancer, anecdotally, people have said that breast cancer is one of the best cancers to have because people have much more sympathy towards people with breast cancer compared to other diseases or even other cancers, for example. So maybe psychologically, they don't face the stigma that other diseases face. Compared to depression, for example, it's a mental disorder. In many parts of the world, it's being stigmatized. Alcohol use disorder, in the context of Denmark, it could not be as severe in terms of psychological burden because alcohol use is fairly well accepted in the Danish society compared to other places, maybe. However, if you then look at social impact, so how this disease impacts people around you and your relationship with them, alcohol use disorder may have huge impacts for your children, for your spouse, and that may translate into children's educational differences in the future, and so on. And again, this may not be accurate, but you can kind of get the sense that if you not just health, but there are other aspects that people experience because of this disease. Another challenge that this project would face is the fact that these diseases tend to affect people who are in different socioeconomic demographic groups. So breast cancer tends to affect, in Denmark, women who are richer, older women. Alcohol use disorder tend to affect people who are younger and poor men. And depression is a bit of a mix of both. And so how do you consider this when making decisions? Back to the earlier slide about can you compare the experience burden between these people, given that they are very different from the beginning? So one kind of conclusion I would like to get from this would be to say, oh, then comparing the ultimate, all the experience that this person or this group has, can we say, oh, this group is affected more or this group is affected less, as a way of facilitating priority setting conversations? But the challenge is these things are there. How do you say, for example, you can say maybe in terms of actual facts, like facts from the data, you can say that economic impact among women or among people with breast cancer are higher, but it shouldn't lead to the conclusion that therefore breast cancer should be a priority in terms of reducing economic impact across other diseases. That should not be the conclusion. There should be much more conversation around, okay, who are we talking about? What are the factors that are affecting these results? This is a challenge. I don't have the answer about how to deal with this yet, and I've had conversations with multiple people in this room about this. And so this is a challenge that I would like to tackle through this project. Ultimately, with this project, with this framework, I would like to look at 5 dimensions, non-health dimensions: economic, social, psychological, as I mentioned earlier, plus quality of life, and healthcare and welfare utilization. And with this framework, I think there are 3 interesting perspectives that we can take. The first is looking within one disease. So looking at breast cancer, for example, what are the different dimensions and how big or small relative to other dimensions they are. And this could be of interest to patient groups, disease-specific interest groups, industry, to think about how can we improve based on, if you're interested in breast cancer, how can we improve the other aspects of the disease impact. We can also look across one dimension, and between different diseases. So for finance ministries, for example, they might be interested in seeing that certain diseases, and therefore certain populations that are being affected by the disease, tend to get disproportionately greater or less welfare transfers than other diseases, and what to do about it. And then the third perspective, and it's the most complicated, I think, but also the interesting aspect, is to compare across diseases, across dimensions. And so similar to what the global burden of disease did to try to compare mortality and morbidity across countries, across years, across diseases, perhaps we can try to take a systematic approach in looking at horizontally across all these different things. And it's a big challenge. So I don't even know if I can do it or not. Next year, I might come and present something completely different. And then you'll realize that, it didn't work out. You never know. So when I received the offer to join DIAS, Jim Valpel, who's one of the chairs of health sciences at DIAS, gave me this advice. And his advice was, to think about a theory or a concept or a method that you've been thinking about and you want to test, and bring it to Denmark and test it using the Danish data. Because Danish data, as many of you may know, is one of the best data you can have in the world in terms of studying population dynamics. I think probably many of you know everything that you do is collected in the Danish system. What is it? Even like logging onto the bank, I have to use my NemID. Like everything is linked to through your CPR and other things. And so it's great for researchers like us who can study the different relationships between different people and how disease impacts when you get the disease, how it impacts before and after you get the disease. And so I didn't think too much about what Jim Valpel said at that time, but then I come here and I realized actually this could be a great testing ground for me to not only to test my own idea, to have a proof of concept and try to communicate it and kind of tweak it based on what findings I find or methods that work, that don't work, and I can try to test it. But also it will give me an opportunity to learn more about the Danish system. Now that I'm here, I'm very interested in how the Danish system works, how data works, how the population, how can they have this great of a welfare state and such. And so this would be a good opportunity also for me to learn about Denmark. So I've listed some of the objectives that I would like to achieve in this project. And I've so far talked to close to 20 Danish researchers on this topic, trying to kind of pitch ideas to see if there's any flaw or anything I can work to improve. And so far, I've received positive feedback that this could be something that could be useful for real life in policymaking in Denmark. There have been some people who sit on boards of priority setting groups in Denmark, and they said something like this, especially comparing across dimensions and across diseases would be a very nice add when they're having discussions about which ones to prioritize. Okay. The last thing is I want just spend the last 2 minutes talking about the other projects I have in case this is of interest to any of you here and you want to discuss more. And this is just a very brief summary of my research ideas and in the spirit of speed dating. First is I'm working with some economists on estimating health-adjusted income. And this idea is GDP per capita itself is not a good measure of well-being of a population, yet we use it all the time to look at which countries are performing better or worse. Can we add a health component to it? That's the short summary. The other 3 projects are all related to my passion around women and girls and health and empowerment of their lives. One is around the effect of age-disparate relationships on women, on girls' life course. So age-disparate relationships are typically among young women, like very young, less than age 25, and much older men. And I mean, Woody Allen is not Zimbabwean, but I'm studying this in the context of Zimbabwe. And this has been so far studied among the HIV research community, and because HIV incidence tend to be much higher in younger women than younger men, and one of the reasons they think is because HIV come from older men to this younger generation. But at the same time, in public health, we tend to have a quite paternalistic view of saying certain things are right and certain things are wrong. And in this case, most people say this kind of relationship is bad. But then you look at places like Tokyo, where people are not poor and they have these relationships among high school girls. You look at Hollywood, it happens all the time. And there should be a rational, I think women, they should have some agency of deciding why they do this. Is it rational or not? And my study wants, what I'm trying to do is to quantify it, to empirically see whether that's the case. Can we see that actually people who go into these relationships tend to fare better or worse in certain life outcomes later on? The next project is around the cost of COVID policies on women and girls, and this is again in Zimbabwe. And the last one is on estimating the prevalence of female genital mutilation in Denmark. So it's kind of all over the place, but in case anyone is interested in chatting more about it, I'm happy to talk about it. And I want to conclude with two things that I'm grateful for. One is when I discuss what I do or how my lifestyle is here in Denmark and what kind of research I'm doing and the freedom I have to do whatever I want in terms of research projects, my colleagues and my people in my network, I don't think they understand. And the reason is, I think, because it's very rare that people, junior folks like us, get this opportunity to explore whatever we want to do. And so I'm grateful for Diaz for giving this opportunity, and also to actually be supportive of the fact that these are happening. And especially there are some people here in the room, so Cor Christensen, yes, and Christina and Jim Baupel also, they were involved in some of during my recruitment process and project development. And they've just been unconditionally supportive of whatever I do. And I think it's a very luxurious thing to have for someone like me. And the second thing is, I've been impressed by how open the Danish colleagues have been. So I'm a foreigner. I don't know about the Danish system. I don't know about the data registries and things. And I come with this big idea and I try to do it. And I'm talking to this person, to that person in different universities and try to pitch my idea. No one, first of all, everyone has just been open and very kind and generous with support and offering resources. And no one has told me, like, it's just been very supportive. And I think the openness of the Danish academic groups have been quite inspiring to me. And for example, the couple of the colleagues that I mentioned here, I think I told them I'm interested in women and girls research. I don't have experience in doing so. These are my skill sets. These are my gaps. I would like to work with you. And they just said, okay, look at my data. What do you think? What do you want to do with it? Let's work together. It's like zero constraints or concerns about some external person coming in and working with them. And so I've just been very impressed by this academic freedom and the environment that I've seen so far. So thank you very much. That's all for me, and I'm happy to take your questions. Yeah.
So thank you very much for the very, very nice talk. And you're talking about that Denmark is one of the best places to have the data analyzed. So how easy you can access the private data? And for example, you talk about the CPR and all this stuff. And how can you easily to get this data? And when you concern about this data protection policy?
Yeah, so I imagine other people in this room can say much more about it. So my understanding is that if you're a research institute, then you have the privilege of applying for data and getting access. You have to get it through Statistics Denmark, or in our case, Statistics Denmark or Health Authority, a Danish Health Authority. And it's a very thorough process of you have to apply for data. You have to have a very specific research purpose what should the outcome be, what variables you're looking at, and they're quite strict in reviewing the applications to ensure that. You can't, and they restrict on what you can report once you have the data, meaning that it has to be based on your application, and they have to approve. For example, even if you have certain data that later you realize, actually, I can do this in other studies, you can't immediately publish that. You have to go through the approval process. It's all anonymized, and I think they've been very good, and it seems like the population of Denmark is also very open to this kind of like having the data shared. But the application is not first of all, not everyone can apply. So people in research institutions, we can apply, and it takes a long time. So that's another barrier. And it's not that you apply for data and you can get it immediately. The access and everything is quite strict. Yeah, Keith.
So when you're thinking of constructing these indices specific to each disease, a lot of these diseases are comorbid. And also a lot of these diseases might be actually proxying for an underlying condition that is not actually being reported in your data set. How are you going to address those types of concerns?
Yeah, I think that is kind of my second stage concern. First, I want to start with diseases that are well-defined and likely have less comorbidities to be clean, and then later I can tackle that. The one way to do it, for example, is first of all, I can only rely on the diagnoses that people have made. If there are no diagnoses, there's nothing I can do about it. So once you have the diagnosis, then you can separate it out into people with and without comorbidity and look at the effects of that. It gets tricky once for example, the global burden of disease, they don't account for comorbidity, and that's an issue. But that's kind of a trade-off in doing a large-scale study without taking into account comorbidity. But that is something that I need to work on, but in a later stage. A good question. Yes?
Thank you for a very good talk on a very ambitious research project. I was also interested at the end of your main discussion, you said you aim to also build frameworks, as you mentioned, for trade-offs.
Yeah.
Now that's very important work, as you know. Most people, including policymakers, not just citizens, find thinking in terms of trade-offs very hard. So could you expand a little bit on how you propose to go about that? I imagine there's lots of ethical, normative elements involved here.
Yeah.
Or questions of incommensurability and so on.
Yeah. Thank you for the question. It is a very important part, especially if this project wants to be of policy relevance, then this is a very important topic to think about. For now, the way I've been thinking about is I'll kind of looking at my earlier framework with different dots. I'll start with the dots first without considering trade-offs, and I'll present the numbers as is because I think the priority setting comes second. It's important, equally important, if not more important, but it comes second to analysis. So my idea right now is to present the analysis first, and then clearly identify what things need to be discussed in order to move from the analysis to the interpretation for policy making. And there could be some guidelines to think about, okay, have we considered differences in sex? Have we considered differences in income? And because ultimately that is not a judgment for me to make. It depends on who the target audience is. So my first piece that I want to do well is the analysis itself. And then what I plan to do is to work with people who have real experience in priority setting to see what kind of questions come up and how can we do the step 2 of moving the analysis to interpretation. And in academia, there are different quantitative frameworks even to make trade-offs. Like there's what's it called? MCD, multiple criterion decision analysis. There are lots of things in decision science that people do on how to make these trade-offs. And they're all based on different weights. So it depends on how you choose to put weights. And that is not something that me as a researcher in this project have the capability of setting. It depends on, again, who's using the data, who's using the analysis to inform policy. And so that, my sense right now is to tend to move away from that conversation, try to guide the conversation, but not give them the final answer. Yeah. Yes, Maria.
Thank you very much for a nice presentation. have a bit of a technical question. So my understanding was you want to bring a lot of registries together, so it's a lot of data. How computationally challenging it is, and how you're going to do it? So will it be all done on Statistic Denmark server? So how technically difficult it is?
So far, I don't think, you can tell me if I'm wrong, because I don't have the data yet. It takes a long time to get the data. I don't have the data yet. My sense is that it's not that much of data, meaning that there's 6 million, at most 6 million people. I only look at adults. 6 million people across time. I don't know how many that would be. I'm only looking at 2-3 variables per dimension.
Right, okay.
And I have a bunch of so I have the disease diagnoses kind of variables, and then I have different, for each dimension I have maybe 2-3 variables, and I can construct them if I need to combine them. Based on my previous experience with data, I don't think this is computationally challenging yet. But other people may correct me. Maybe I'm naive. I don't think it has reached the limit that I'm expecting.
I just didn't know how much variables you need to construct with data, how much distribution you need to make.
Yeah. Thank you. Any other question?
No more questions? I have one last
Yeah.
one for you.
Yeah.
I was just thinking about a group of patients that have received renewed attention now, which have been very overlooked in Denmark, but are now gaining attention because we have these long COVID people starting to complain from syndromes that are quite similar to the people who have suffered from chronic fatigue syndrome, ME, and so on. I was thinking while you were talking that it would be so, I think that's one of the groups of people in Denmark that are suffering most experience burden of disease compared with what you can just maybe measure in terms of DALYs or something like that. But also at the same time, while I was thinking it would be interesting to do your experience burden of disease index on this group of patients, I thought, perhaps it's also going to be very stigmatizing if you suddenly come out as a group with a disease that's very not only costly in terms of DALYs but also in economy and social effects and so on. So how have you thought about, well, I guess partly one, could there be stigmas associated with this, and two, also to involve patient groups in whatever you do and have kind of ongoing conversations with them about it?
Yeah, I think I'm not a disease expert, so for certain diseases, there may be aspects that I didn't think about that affect the patients much compared to others. For now, because I'm trying to take small steps, because I think it's a big ambitious goal, so I'm trying to take small steps, and I think that interacting with groups would first require me to have some sort of proof of concept with clean kind of disease diagnosis with people with no comorbidity and simple cases to show. And then I would like to talk to patient groups or industries or policymakers who can help me think about, are there other dimensions that I missed that should be captured? Or are there other variables that the registries have that I should consider? And that will be a next step. But the group that you're mentioning seems to be one of the more complicated cases, because my guess is they're probably older with more disease burden of other diseases. But it's infectious disease, COVID.
It's still disputed, and even diagnosis is disputed. So it's not going to be your best showcase.
Yeah,
but I was just curious.
Yeah, I think ultimately I would like to do that. And actually another ultimate thing I would like to do is to compare across countries. I think it's very difficult because I don't even know how to think about it, but imagine thinking about especially countries with similar data structure. I might be able to do similar things and compare how, and especially the question I like to answer is, what specific context of that country affects disease burden so much? Thinking about blindness, for example, right? Is it the traffic? Is it a welfare system? What is it that affects having the same disease but in a different country so differently? And being able to do cross-country comparisons would be great. I don't think it's feasible based on what I know right now, but that's something I would like to go ultimately. So there are lots of things I would like to do in the future, but I've been encouraged by many people to take small steps at a time.
Which I think makes sense, but on the other hand, you can't start
Yeah.
thinking about, also within Denmark, what would differ which kind of groups could you subdivide patients into that would have different experience burden of disease compared with but I think that's again a characteristic of a great idea. It makes us think, and it makes us think forward and ask new questions. So I think if there are no further questions, I will close the session with this and just say thank you very much for entertaining us so well for this seminar, and thank you to all the audience. And should we give Angela a big hand?
Thank you.